Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of epiglottitis in children, designed for general pediatricians and exam candidates. Epiglottitis is one of the most dramatic and dangerous airway emergencies in pediatrics. Although its incidence has dramatically declined since the introduction of the Haemophilus influenzae type B vaccine, every pediatrician must instantly recognize this condition because delay of even minutes can be fatal. We will work through 10 carefully crafted clinical cases covering clinical recognition, initial safety management, etiology, airway anatomy, imaging, differential diagnosis with croup, definitive diagnosis, antibiotic therapy, public health and chemoprophylaxis, and life-threatening complications. Let us begin. Case 1. A 4-year-old girl presents with a 6-hour history of high fever at 39.8 degrees Celsius, severe sore throat and muffled voice. She is sitting upright, leaning forward with her chin thrust out, and is drooling. She has no cough. What is the most likely diagnosis? Option A, acute epiglottitis. Option B, viral croup. Option C, retropharyngeal abscess. Option D, bacterial tracheitis. The correct answer is option A, acute epiglottitis. This case demonstrates the classic textbook presentation. The hallmark clinical features of epiglottitis are summarized by the 4 Ds. The first D is drooling, reflecting the child's inability to handle oral secretions due to severe odonophagia and painful swallowing. The second D is dysphagia, painful or difficult swallowing. The third D is dysphonia, a muffled or hot potato voice caused by the swollen epiglottis obstructing sound. The fourth D is distressed inspiratory stridor, a high-pitched noise on inspiration indicating supraglottic airway obstruction. The tripod position, sitting upright and leaning forward with the chin thrust out, is a protective posture the child instinctively assumes to maximize airway patency. Rapid progression over hours, high fever, and a toxic appearance are characteristic. Critically, the absence of a barking cough strongly distinguishes epiglottitis from croup. Case 2. While evaluating the 4-year-old girl, she becomes increasingly agitated. Her oxygen saturation is 94% on room air. What is the most appropriate next step? Option A. Perform a thorough oropharyngeal examination using a tongue depressor. Option B. Obtain an immediate posterior-anterior and lateral neck X-ray. Option C. Keep the child calm and allow her to remain in her mother's lap. Option D. Start an intravenous line for immediate fluid resuscitation. The correct answer is option C, keep the child calm and allow her to remain in her mother's lap. This is arguably the single most important management principle in pediatric epiglottitis. The supraglottic airway is critically narrowed and edematous, and any agitation can trigger sudden total laryngospasm, leading to complete airway obstruction within seconds. Therefore, any procedure that distresses the child must be avoided in the emergency department. Do not use a tongue depressor for oropharyngeal examination, as this can precipitate fatal laryngospasm. Do not force the child into a supine position. Allow them to remain in their position of comfort, usually the tripod position. Do not attempt intravenous line placement or blood draws in the emergency department before the airway is secured. The correct approach is to keep the child with their caregiver, provide blow-by oxygen if tolerated, and immediately mobilize the airway team consisting of anesthesia, ear, nose, and throat surgery, and pediatric intensive care to transfer the child to the operating room for controlled airway management. Case 3. An unimmunized 3-year-old boy presents with classic signs of epiglottitis. Historically, which pathogen was the most common cause of this condition in the pediatric population before widespread vaccination? Option A. Streptococcus pneumonia. Option B. Haemophilus influenzae type B. Option C. Staphylococcus aureus. Option D. Group A Streptococcus. The correct answer is option B. Haemophilus influenzae type B. Before the introduction of the Haemophilus influenzae type B conjugate vaccine in the late 1980s and early 1990s, this gram-negative coccobacillus was by far the most common cause of pediatric epiglottitis. The disease typically affected children aged 2 to 7 years and presented with the classic rapid, toxic clinical picture. Following widespread vaccination, the incidence in children under 5 years of age has dropped by more than 95%. For example, surveillance data show incidence falling from approximately 31 cases per 100,000 children in 1985 to less than 0.1 per 100,000 by 2020. In vaccinated children today, when epiglottitis does occur, the responsible organisms have shifted to Streptococcus pneumonia. Other Streptococcus species, Staphylococcus aureus, including methicillin-resistant strains, and occasionally Group A Streptococcus. This shift directly informs our empirical antibiotic choices, which we will discuss in a later case. Case 4. Epiglottitis involves acute inflammation and edema of specific airway structures. Which of the following groups of structures is primarily affected in this condition? Option A. Subglottic space and vocal cords. Option B. Palatine tonsils and peritonsillar tissue. Option C. Tracheal mucosa and subglottic region. Option D. Epiglottis and ariepiglottic folds. The correct answer is option D, the epiglottis and ariepiglottic folds. Although called epiglottitis, the condition is more accurately termed supraglottitis because the inflammation involves not just the epiglottis but the entire supraglottic region, including the ariepiglottic folds and the arytenoid cartilages. The supraglottic structures lie above the level of the vocal cords. This anatomical distinction is critically important because it explains the clinical features and differentiates epiglottitis from croup. Croup, also known as laryngotracheobronchitis, is a subglottic process with inflammation below the vocal cords narrowing the subglottic space. In epiglottitis, the subglottic space is typically spared. The proximity of the inflamed epiglottis to the laryngeal inlet is what makes this condition so dangerous. Rapid edema can completely occlude the supraglottic airway with no readily accessible space below the obstruction to bypass with simple maneuvers. Case 5. A lateral neck X-ray is performed on a stable patient with suspected epiglottitis. Which radiographic sign is most characteristic of this diagnosis? Option A. Thumbprint sign. Option B. Steeple sign. Option C. Prevertebral soft tissue widening. Option D. Shaggy appearance of the trachea. The correct answer is option A, the thumbprint sign. On a lateral neck X-ray, the inflamed and edematous epiglottis appears as a rounded, thickened, soft tissue density resembling the shape of a thumb, hence the name thumbprint sign. Additional radiographic findings include thickening of the ariepiglottic folds and obliteration of the vallecula, the normal pouch between the base of the tongue and the epiglottis. However, there is a critical caveat. X-rays should only be obtained if the patient is hemodynamically and respiratorily stable, and if airway experts are physically present and ready to intervene. A child with epiglottitis must never be sent unaccompanied to a radiology suite. For comparison, the steeple sign refers to subglottic narrowing on a posterior-anterior neck X-ray and is characteristic of croup. Prevertebral soft tissue widening suggests retropharyngeal abscess, and a shaggy tracheal appearance suggests bacterial tracheitis. In practice, when epiglottitis is clinically suspected, direct visualization in a controlled setting takes priority over imaging. Case 6. Which of the following clinical features most strongly differentiates epiglottitis from viral croup? Option A. Presence of inspiratory stridor. Option B. Use of accessory muscles for breathing. Option C. High fever and absence of barking cough. Option D. Response to nebulized racemic epinephrine. The correct answer is option C. High fever and absence of barking cough. Distinguishing epiglottitis from viral croup is one of the most clinically important diagnostic decisions in pediatric emergency care. Several features differ sharply between the two. Onset is rapid in epiglottitis, often over hours, but slow and gradual in croup, typically over 1 to 3 days. Fever is high, often above 39 degrees Celsius in epiglottitis, but is low-grade in croup. Cough is absent in epiglottitis, while the barking, seal-like cough is the signature feature of croup. The child with epiglottitis appears toxic and prefers the upright tripod position, whereas croup patients are generally less ill-appearing. Radiographically, epiglottitis shows the thumbprint sign on lateral neck X-ray, while croup shows the steeple sign on posterior-anterior neck X-ray. Inspiratory stridor and use of accessory muscles occur in both conditions and are not discriminating. Importantly, croup typically responds dramatically to nebulized racemic epinephrine and corticosteroids, whereas epiglottitis does not respond to racemic epinephrine because the obstruction is mechanical edema in the supraglottic region. Case 7.